Hi and welcome to a new episode of your weekly medical TV show on الكرمة TV, White Coat. Today we'll continue talking about the same painful topic, which is chronic pain. We'll talk about the latest procedure that help to manage that chronic pain. Throughout the world, 1 out of 5 suffer from moderate to severe chronic pain. And in a country like the United States of America, chronic pain is affecting more people than cardiovascular disease, cancer, and diabetes combined. Chronic pain is one of the most common reasons for seeking medical attention, second only to respiratory disease. Today we'll focus on chronic pain, neck pain, joint pain, and sciatica. We'll discuss the latest minimally invasive procedure that help to manage different kind of chronic pain, and it's my pleasure today to host one of the outstanding physicians in Southern California in the chronic pain management field, Dr. Rostam Khoshsar, to educate us more about chronic pain management, injection, and minimally invasive procedure. For interaction with the program, send in all your questions and concerns to our official Facebook page, Coat Alkarma TV. Or if you want to interact with my guest directly today, you can call the numbers that will be shown on the screen at any time during the episode. We will be more than happy to answer all your questions. To keep up with us, follow our Facebook page, Coat Alkarma TV, or follow our Instagram page, Coat Alkarma. Or to watch our latest episodes, please subscribe to our YouTube channel on الكرمة TV and activate the notification bell. أعزائي مشاهدي قنوات الكرمة في كل مكان في العالم، بحب أرحب بيكم في برنامجكم الطبي الأسبوعي وايت كوت. الحقيقة عملنا حلقة أو الجزء الأول عن الآلام المزمنة وأحدث طرق العلاج ليها. اتكلمنا عن فكرة العلاج بالحقن، مش بس بالحقن عموما النخاع الشوكي، اتكلمنا كمان عن حاجة اسمها الفاسات نيرف بلوك، اللي هو الحقن في المفصل السطحي اللي بيبقى موجود بين الفقرات وبعضها. فدي كانت حلقة عملناها جزء أول اتكلمنا فيها عن كل الحاجات الجديدة في الحقن، سواء كمان الانديكيشنز بتاعتها، سواء الأعراض الجانبية، مين اللي يقدر يعمل الحقن، نقدر نعمله قد إيه. اتكلمنا على كل الحاجات دي في الجزء الأول. الحقيقة النهاردة قررنا ان احنا نعمل الجزء الثاني عشان نتكلم على موضوع علاج الآلام المزمنة، لانه كتير من الناس بتشتكي من فكرة علاج الآلام المزمنة. زي ما دايما بنحب ندي شوية احصائيات في اول البرنامج، تقريبا 1 من كل 5 على مستوى العالم كله بيعاني من فكرة الآلام المزمنة، سواء في آلام الرقبة، آلام الفقرات بشكل عام، الآلام في الذراعين او في الرجلين، او آلام الظهر المزمنة بشكل عام. فالحقيقة 1 من كل 5 على مستوى العالم بيعانوا من ده. الناس اللي بتعاني من فكرة الآلام المزمنة على مستوى العالم قد مرضى السكر والكانسر والأمراض القلب على بعض كده. الناس اللي بتعاني من أمراض مزمنة هم أكتر من الناس دي على بعض. فالحقيقة موضوع مهم بيشغل يعني حيز ناس كتيرة قوي مهتمة بالموضوع ده. احنا كمان زي ما دايما بنحاول في وايت كوت ان احنا نجيب لحضراتكم احدث طرق العلاج في كل حاجه. النهارده هتبقى حلقه خاصه جدا هنتكلم فيها على 3 انواع العلاج امراض او الالام المزمنه بشكل عام. هنتكلم على حاجه اسمها الرايزوتومي، او اللي هي بنسميها الموجات الكهرومغناطيسيه، يمكن من احدث الحاجات اللي بتستخدم، واستخدام جهاز بيصدر موجات كهرومغناطيسيه تشتغل على النيرفز او على الاعصاب اللي موجوده ما بين الفقرات في النخاع الشوكي. الحقيقه نسب نجاح كبيره جدا للجهاز ده، وهنتكلم على مين اللي يقدر يعمل الحاجات دي، مين الجود كانديديت للبروسيجر دي، ايه هي الكونترا انديكيشنز، الناس اللي ما تقدرش تعمل خالص الموضوع ده، وايه البدايل في الحاله دي. هنتكلم بعد الجهاز الجديد اللي بالموجات الكهرومغناطيسيه او الرايزوتومي، هنتكلم على حاجه اسمها السباينال كورد ستيميوليتور، اللي هو محفزات او جهاز بيبقى صغير كده بيتحط جنب في العمود الفقري جنب النخاع الشوكي، بيحفز السباينال كورد ان هو يتغلب على فكره الكوندكشنز بتاع الالم اللي طالعه من النيرف. هنتكلم على ده كمان النهارده. كمان هنتكلم على احدث حاجه في العالم اللي هي الفيرتيفلكس. ده موضوع مهم جدا هنتكلم عليه، واحدث تكنيك يمكن في العالم كله اللي هو السبيسر للتغلب على الامراض المزمنه، وبالذات الالام المزمنه، وبالذات في فكره امراض العمود الفقري، وتحديدا اللي بتاثر على الاطراف بشكل كبير جدا. هنتكلم كمان على حاجة برضو جديدة جدا في العالم. الحقيقة النهاردة حلقة هتبقى يعني لطيفة جدا، لأنه هنعرف أحدث الحاجات اللي بتستخدم في الكلام ده. زرع مضخة صغيرة بتبقى اللي هي البامب بنحطها، وهي بتتنظم بشكل معين بحيث ان هي تضخ كمية معينة من الدواء على النيرفز دي. وطبعا بتبقى اندر ريجيليشن بشكل كبير، نفس فكرة الانسولين بامب اللي هو الجهاز اللي بيتزرع لتنظيم انه يدي انسولين للجسم في اوقات محددة. فدي عملوها بفكرة تانية، ان هم يحطوا او البامب دي تحط ادويه عشان تسكن الالام دي. كل ده هنتكلم عليه في حلقتنا النهارده، احدث الطرق لعلاج الالام المزمنه. سعيد جدا بالحلقه دي، سعيد جدا بضيفي اسم كبير جدا في المجال ده هنا في كاليفورنيا. هيكلمنا على كل الكلام ده، هو بيعمل كل البروسيجرز دي. يعني حاجة تشرف انه يكون معانا ضيف بالحجم ده بيعمل كل البروسيجرز الادفانسد قوي دي. هنا هنسمع منه، هنتعلم منه عن الجديد في علاج الآلام المزمنة. فالحقيقة ربنا يدينا حلقة تكون مختلفة. زي ما حضراتكم عارفين دايما التواصل اللي بيننا وبين حضراتكم بيبقى موضوع مهم جدا. سبورت الكبير جدا من حضراتكم على السوشيال ميديا بيبقى مهم جدا لكل قنوات الكرمة، وكمان تحديدا لوايت كوت، لانه احنا بنعرف من خلال حضراتكم ايه الحاجات الجديدة، ايه الحاجات اللي عجبت حضراتكم، الاسئلة اللي حضراتكم بتحبوا تسألوها في كل موضوع بنحاول نجاوب الحقيقة على معظمها. فمهم جدا فكرة التواصل عن طريق السوشيال ميديا، وخاصة البلاتفورم اللي أنا بعتبرها الأهم، الفيسبوك، زي ما حضراتكم شايفينها على الشاشة دلوقتي. تقدروا تبعتوا لنا كل أسئلتكم على صفحتنا الرئيسية على الفيسبوك وايت كوت الكرمة تي في. تقدروا تبعتوا كل الأسئلة عن اللي بتخص الآلام المزمنة، أو حلقة بحلقة عن ما يخص موضوع الحلقة دي بشكل عام. كمان في وايت كوت الكرمة، ده الانستجرام بتاع البرنامج. تقدروا برضو تبعتوا لنا كل اسئلتكم على الانستجرام بتاع البرنامج. البلاتفورم الاهم او واحده من البلاتفورمز المهمه جدا هي اليوتيوب. تقدروا تعملوا سبسكريبشن على قناه الكرمة على اليوتيوب، هيوصل حضراتكم اخر واحدث الحلقات في كل البرامج على قنوات الكرمة عن طريق ان احنا نعمل سبسكريبشن زي ما شايفين على الشاشه. بعد كده نفعل زر التنبيهات عشان توصلنا اخبار الحلقات اول باول. زي ما بقول دايما السوشيال ميديا مهمه جدا، دعم حضراتكم مهم جدا، والتواصل عن طريق السوشيال ميديا، لانه احنا هنا موجودين عشان نخدم حضراتكم. فحضراتكم كمشاهدين هي يعني انتوا البوصله بتاعتنا، انتوا اللي بتقولوا لنا ايه كان كويس ايه كان وحش. الايفالويشن ده بيبقى مهم جدا عشان دايما نتعلم من خلال حضراتكم ايه اللي كان كويس نكمله، ايه اللي ما كانش كويس نطوره. فالتواصل ده بيبقى شيء مهم جدا ما بين أسرة قنوات الكرمة كلها، سواء اللي قدام الشاشة أو اللي ورا الشاشة اللي هو حضراتكم. زي ما قلت النهاردة، موضوع النهاردة مهم جدا، الآلام المزمنة، أحدث طرق العلاج. فزي ما أنا قلت التواصل مهم. ابعتوا لنا رقم التليفون، تقدروا تسألوا كل اللي انتوا عايزينه عن موضوع الآلام المزمنة. متحمس جدا لحلقة النهاردة، ويلا بينا نبتدي فقرات برنامجنا من وايكو.
Are you tired of being overweight? Do you suffer from diabetes? Do you suffer from hypertension? Do you suffer from obstructive sleep apnea? Do you suffer from hypercholesterolemia? Have you suffered from heart attacks in the past? Strokes in the past? Are you tired of being ostracized in public? Well, I have a solution for you. Robotic bariatric surgery. This can completely change your life. I'm Dr. Bobby Baskerau. I'm a robotic bariatric surgeon. I do robotic weight loss surgery, which can completely change your life. I offer 3 different types of surgeries that can completely change your life. The sleeve gastrectomy, the lap band, and the roux-en-y gastric bypass. One thing that's very unique about our program in that we have a dietitian, and you will get counseled on what to eat, what not to eat, and how to optimize the utilization of your tool for good weight loss.
من غير صلاتك ودعمك ما كناش أنتجنا كل البرامج دي. محتاجين لمشاركتك لاستمرار الإنتاج. لما بتعطي دايما بهدف، أو عشان تسد احتياج معين لشخص معين أو مكان معين. لما بتعطي في الكرمة مش بتعطي شخص ولا حتى مكان، انت بتشارك في رسالة حب، وبتشارك في نشر السلام، بتشارك في تنفيذ وصية إلهك. ما تتأخرش لما تجيلك فرصة، اعطي بس من قلبك.
I'm Dr. Rostam Khoshsar. I'm an anesthesiologist with subspecialty fellowship training in pain management. I'm board certified in anesthesiology and pain management both. I finished my medical degree at Tehran University and I moved to US. I did my surgical residency at State University of New York in Buffalo, followed by anesthesiology residency at Drew UCLA Medical Center and fellowship training in pain management at UC Irvine, where I stayed as a faculty after finishing my fellowship training, and I'm currently a faculty of UCI. I'm also director of anesthesia pain clinic at the Veteran Hospital in VA, which is a hospital that treats the US veterans. I'm also medical director of biohealth pain management. As you see, I'm very busy with treating patients in pain at UCI, at the VA hospital, and also in my private practice, biohealth pain management. I do a lot of research in the field of pain management. One of the most recent research that we did at the Veteran Hospital was regarding patients with PTSD or post-traumatic stress disorder, which I treat them by doing a stellate ganglion block, which is a nerve block in the neck. And that was filmed and aired by CBS 60 Minutes show just recently. Besides practicing medicine, I try to spend as much time as I can with my family and my kids. My hobbies are camping, hiking. I try to exercise and work out and stay physically fit. I do bike riding usually on Sundays and try to have a balanced life between practicing medicine and my family. I truly appreciate my family considering the fact that a physician's life is not as easy and I have to spend time with the patients, with the practice, hospital, and also spend time with my family as well, as much as I can, and thankfully they understand that. Stay tuned for me at White Coat program at الكرمة TV.
انت اهم واحد في الحياة لانك ممكن تغير العالم كله. مش مصدق؟ فكر لو عملت شير لفكرة على الفيسبوك، كل اصحابك هيشوفوها. فكر كمان لو كل واحد من اصحابك نشر الفكرة لاصحابه واصحابه نشروها لاصحابهم. فكرتك البسيطة سهل جدا تنتشر. ده ممكن تكون نهضة، مش بس تنتشر، تغير في ناس كتير في العالم كله. شارك النهاردة وشير من على فيسبوك الكرمة الرسالة دي.
اهلا بحضراتكم مره تانية. الحقيقه موضوع مهم جدا في العالم كله، زي ما نقول الالام المزمنه. ناس كتير جدا بتعاني من فكره الالام المزمنه. زي ما انا قلت، لو جبنا كده كل مرضى الكانسر وكل مرضى القلب وكل مرضى السكر على بعض وجمعناهم، هيطلع عدد المرضى اللي بيعانوا من الالام المزمنه اكتر من الثلاثه مجتمعين على بعض. حلقه مهمه جدا. دايما بفكر حضراتكم صفحتنا الرئيسيه على الفيسبوك كوت الكرمة تي في، تقدروا تبعتوا كل اسئلتكم. هي احنا اوريدي الاسئله بدات تيجي على الحلقه اللي فاتت اللي اتكلمنا فيها. زي ما انا قلت الجزء الاول اتكلمنا فيه على العلاج بالحقن. النهارده هنتكلم على حاجات مختلفه تماما. هنتكلم على حاجه اسمها الرايزوتومي او الموجات الكهرومغناطيسيه. هنتكلم على حاجه اسمها السباينال كورد ستيميليتور او محفز النخاع الشوكي. هنشوف فكرته بتبقى عامله ازاي. هنتكلم كمان على المضخة الجديدة الصغيرة اللي بتتزرع، اللي يعني بتحط زي مسكنات على الروتس أو الجذور بتاع كل الأعصاب اللي بتبقى موجودة في النخاع الشوكي. هنتكلم على أحدث الحاجات بيزيكلي اللي بنتكلم فيها على علاج الأمراض المزمنة. It's a pleasure and honor to have Dr. Rostam Khoshsar, second time in White Coat. First episode was extraordinary. It's always a pleasure having you, Dr. Khoshsar.
Thank you. It's always a pleasure to be here.
Chronic pain. I said in my intro, people suffer from chronic pain is more than people suffer from cardiovascular disease, cancer, and diabetes combined. So it's a big topic.
Sure.
In pain management specialty, when we say pain management specialist, what do we mean by that? What kind of disease or conditions do you manage as a pain management specialty?
So, as you mentioned, pain management is a big issue, is a big problem in any community, especially in the U.S. It costs billions of dollars.
Okay.
So there is a need to train physicians to be specialized in pain management,
Right.
to treating the pain. So a pain management specialist is a physician. They're usually anesthesiologists or rehab, physical medicine rehab specialists. They do special training in pain management, which is called fellowship training.
Okay.
By doing that, they learn how to treat the pain, not just by medication, but also by doing minimally invasive procedures such as injections, nerve blocks, epidural injections, minimally invasive procedures such as devices that we put in to treat the pain.
Okay.
So pain management specialist is trained and is skilled to treat the pain using minimally invasive procedures. So they have special training as a subspecialty, usually to anesthesiology.
Okay.
What kind of pain do they treat? Any kind of pain.
Okay.
I mean, we treat neck pain, back pain, nerve pain, abdominal pain, cancer pain. So any kind of chronic pain that a primary physician or the primary specialty like the surgeon cannot treat, or beyond that scope, and the patient falls in a category of chronic pain, they're usually referred to pain management specialists.
Okay, perfect. Since the most repetitive word you have used is chronic pain, how big is the problem of chronic pain, like statistics-wise?
Chronic pain, as you mentioned, it's a big issue. I mean, the incidence of chronic pain is way more than diabetes, coronary artery disease, and cancer, like total combined.
Combined, right.
Every day, there are people that are losing work because of pain, especially low back pain. So low back pain by itself, or chronic pain by itself, it costs about $100 billion.
$100 billion.
In medical care, loss of wages, welfare, putting a lot of harm on businesses by people not being able to go to work.
Right.
So that is a big issue, and there is a need to get it under control.
And I believe number one admitting goes to, like,
Number
now
one
and then
admitting
it's-
diagnosis is pain.
Wow.
Like more than 70-80% of people that go to the emergency room,
because of pain.
they go because of pain.
Right.
Now, the reason for pain could be something else, but the main reason of going to the emergency room is pain.
اوكي. الحقيقه سؤالي الاولاني لدكتور كوشار كان بيتكلم على احنا قاعدين نقول بين مانجمنت سبيشالست، ده يعني ايه يعني ايه الفيلد الجديد اللي طالع في العالم بقاله 15 20 سنه ده. فقال لي احنا بنتعامل عاده مع الالام المزمنه بشكل عام او الالام الحاده بطرق زي ما بنقول بره الصندوق، بره مشرط الجراح انه يفتح او يشيل او الكلام ده. الناس دي ما بتعملش كده، دي بتعمل حاجه اسمها minimally invasive procedures، بمعنى انه الجراحات بتاعتهم بتبقى بسيطه جدا، مش بنفس حجم الجراحات الكبيره، procedures صغيره بيعملوها بطرق وتكنيكس مختلفه، منها الحقن، منها اللي ناقشناه نوعين الحقن المختلفين اللي ناقشناهم في الحلقه الاولى، تقدروا حضراتكم تشوفوها على اليوتيوب. النهارده هنتكلم على علاج الآلام المزمنة بطريقة مختلفة. الناس دي بتعملها بطريقة مختلفة عن طريق زي ما أنا قلت المضخة الصغيرة أو السباينال كورد ستيميليتور اللي هنتكلم عليه بشكل كبير، عن طريق الجهاز الجديد اللي بنسميه الرايزوتومي أو الموجات الكهرومغناطيسية. سألته أكتر كلمة هو أنت رددتها في البداية هو الكرونيك بين أو الآلام المزمنة. قال لي رقم واحد في دخول الناس للمستشفى في دولة زي الولايات المتحدة هي الكرونيك بين. زي ما احنا قلنا في بداية الحلقة أو المقدمة، الناس اللي بتعاني من الآلام المزمنة قد الناس اللي بتعاني من الكانسر والدايابيتس وأمراض القلب مع بعض، أو الكانسر والسكر وأمراض القلب مع بعض. كمان حاجة مهمة جدا، تكلفة بتاع الآلام المزمنة في دولة زي الولايات المتحدة بتتعدى $100 مليار ما بين العلاج وما بين حاجة اسمها loss of productivity اللي هي عدم القدرة على الإنتاج، إنه الواحد ما يبقاش مواطن منتج بشكل كبير. فده $100 مليار يعني ميزانيات دول، احتياطي نقدي لدول. فالحقيقة مشكلة كبيرة جدا، تكلفتها كبيرة جدا. In part one we talked about injections, and since like our first episode I'm still getting questions about it. So I'll have some very quick questions for you about injection before we start the rhizotomy. First of all, you mentioned that the injection has some cortisone in it. Does it affect diabetics? Because that's one of the questions.
Not every injection has cortisone in it.
Okay.
So cortisone or steroid is a medication. It could be injected anywhere.
Okay.
In the joint, in the ligament, in the tendons. But epidural steroid injection is a common thing. So we do inject steroid or cortisone in the epidural space to alleviate the pain, reduce the inflammation around the disc. But your question was whether it has any effect on diabetes, right? Steroid is known to raise the blood sugar.
Okay.
But the effect of the steroid that we inject usually lasts about a couple of weeks.
Okay.
And beyond that, gradually it goes down the blood sugar. So if someone has uncontrolled diabetes, then I suggest not to get the epidural steroid injection. But if the diabetes is under control, if they check the blood sugar every day and they adjust their insulin level or the pills, then it's okay to have the steroid injection as long as they can manage the blood sugar.
Another question about, does it work for the DGDs, like the joint disease in the neck or like any part of the vertebral column, spinal?
For DGD or degenerative joint disease, or sometimes we call it DDD as well, degenerative disc disease, that's one of the treatment is steroid injection.
Okay.
So steroid for joint disease, it helps. Now, when we talk about the joint and the spine, we're talking about facet joints usually.
Okay.
Facet joints, I mean, there are different way of treatment of facet arthropathy or joint disease in the spine. One of them is injecting steroid in the joint or around the joint. So to answer the question, yes, it helps with the DJD, but there are also other ways to treat the DJD as well.
Okay, perfect. الحقيقة من أكتر الأسئلة اللي جات لي في الحلقة الأولى وأنا حاولت أجمع معظمهم هو فكرة زي ما احنا قلنا العلاج بالحقن. والعلاج بالحقن بيبقى فيه أنواع من الحقن، بيبقى فيه حاجة اسمها كورتيكوستيرويدز أو كورتيزونات. كمية الأسئلة اللي جات للبرنامج من الديابيتكس أو اللي هم بيعانوا من مرض السكر، طب هل الكورتيزون ده بيأثر على السكر؟ زي ما قال دكتور كوشار، لو السكر تحت يعني under control والناس الارقام السكر بتاعتها كويسه، الحقن بيأثر لمده من اسبوع ل2 فقط، وده نقدر نزود شويه مثلا نسبه الانسولين او الادويه اللي بتاخدها الناس ونحطها تحت الكنترول. فممكن مرضى السكر لو محافظين على نفسهم يستخدموا الحقن ده. جالي كمان كمية أسئلة كتيرة جدا على أنهي أنواع من الآلام، سواء الرقبة أو الظهر أو اللي هي بنسميها الفقرات القطنية. أي نوع من الحاجات دي بينفع معاهم الحقن، وآلام الرقبة نتيجة تآكل الغضروف بينفع معاهم أنواع الحقن ده، أنواع حقن مختلفة، ولكن في أنواع حقن لتآكل الغضروف حتى لو في الظهر أو حتى لو في الرقبة. كل الأنواع دي بينفع معاها الحقن. فمهم جدا لو حضراتكم عايزين تطلعوا على الحلقة دي زي ما أنا قلت موجودة على اليوتيوب بشكل كبير جدا. Let's start our part 2. We talked about part 1 enough, a lot of injections. Just a reminder for people, if they need help, where do you practice? How many procedures you do? I know but how many procedures you do? What's your website? How can we reach out for help?
Well, my private practice is BioHealth Pain Management, and I believe the number and the info would be on the website, correct?
Okay.
But anyhow, BioHealth Pain Management, the phone number is 424-360-0066. I don't want to blow up your mind by saying how many procedures I do in a week or so.
Okay.
But I roughly do about 40 to 50 procedures a week.
Okay.
Which means that, and the procedure, it varies. Injections, nerve blocks, epidural injections, radio frequency ablation, which we are going to talk about, intrathecal pumps, spinal cord stimulators, Vertiflex. Like this coming Monday, I'm having 2 stem implants, spinal cord stim implants, intrathecal pump trial, intrathecal pump implant, and some other injections and so.
Okay. الحقيقة برضو عشان حضراتكم كل المقيمين في جنوب الولايات المتحدة أو موجودين في الولايات المتحدة بشكل عام، واحد من أحسن الناس اللي بتعمل الحاجات دي دكتور كوشار. الويب سايت بتاعه كان معانا، يا ريت نحطه على الشاشة. بتقدروا حضراتكم لو في أي أسئلة أو استفسارات، التيم بتاعه كله بيجاوب على التليفون، مش لازم يبقى في appointment، ولكن يعني الناس بتجاوب على الأسئلة. لو شافوا إن المريض ده كانديديت كويس لأي بروسيجر بيقولوا له، لو حضرتك مش كانديديت كويس هيقولوا لك من الأول. فالحقيقة يعني براكتس محترم جدا جدا جدا. التليفونات موجودة قدام حضراتكم على الشاشة، لو في أي حد حابب يعني بيسأل حتى ولو نصيحة على التليفون، الناس بتجاوب بشكل كبير جدا. So we talked about injections, different kind of injections. Let's talk today about rhizotomy. What is rhizotomy in the beginning?
What is rhizotomy? That's a very good question. That's a very nice, actually, procedure to do.
Okay.
Rhizotomy or radiofrequency ablation is damaging a little tiny nerve, which is usually a sensory nerve, to treat the pain.
Okay.
Where do we mostly do the rhizotomy or radiofrequency ablation is on the spine.
Okay.
And because of DJD or facet joint disorder, patients who have disc disease, when the disc height decreases, the joints are getting closer to each other.
Right.
So they rub against each other. The patients usually have back pain without radiation to the legs. They may have neck pain without radiation to the shoulder or arm. So the nerve roots are not involved.
Okay.
The problem is coming from the joint.
Okay.
Someone with a facetogenic back pain, they usually have pain that is worse by standing for prolonged period of time, worse by sitting for prolonged period of time. Also in the morning when they first get off the bed, they feel stiffness and pain, and it takes like a little while until they walk around and they stretch and the pain kind of like fades out. So that's classic facetogenic pain.
Okay.
What we do, I mean, the way we treat or I treat the facetogenic pain, first I do a test.
Okay.
Which means I go in and inject a little bit of local anesthetic right by the little tiny nerve that innervates the joint. and block that nerve. If the pain subsides after that,
That means
then it kind of confirms the diagnosis that the pain is coming from those facet joints.
Okay.
Then I repeat the test.
Okay.
So we test it twice. If
Let's make
both
sure.
tests are positive, then we go with this special kind of probe or needle that is connected to the RF machine, a radio frequency generator. It gives radio frequency wave. And what does the radio frequency do?
Slides
Radio
it down.
frequency, it heats up the tissue, heats up the nerve, and we kill the nerve.
Okay.
But that nerve is only a sensory nerve. So it's a nerve that transmits the pain signal to the brain.
Okay.
Once it's gone, the brain is not going to feel the pain of the joint. But that lasts only about 6 months to a year because the nerve regenerates, regrows back again. Once it comes back, we repeat the procedure.
Okay. I'm going to ask you here a question. You said we treat those like cases if the nerve is not involved. What's the difference? Like in a simple language, what do you mean by the nerve is not involved? Like, do we feel numb? Like, what's just for people to understand the difference?
True. Yeah. Very good question. I mean, it's a bit confusing for the patients also when they come in and say, oh, you know what, I have back pain, and then my pain shoots down the leg.
Okay.
Sciatica, basically. I cannot treat sciatica by doing RF ablation or rhizotomy.
That's very okay.
But someone comes to me and says, I only have back pain. I ask him, does the pain shoot down your legs? Do you have sciatica? Do you have numbness or tingling down your legs? Because numbness and tingling down the leg, they're all nerve symptoms,
Okay.
nerve root symptoms.
Okay.
So if the patient has only isolated back pain without radiation to the legs, or back pain and buttock pain without sciatica, I suspect that the pain is coming from the facet joint.
Okay.
Then I go ahead and do the test. If the test is positive, then I'm confirmed that the pain is coming from the facet joint. Then I do the rhizotomy or radio frequency ablation to provide a long-term relief, which means usually 6 months to a year.
Okay. I asked you that question just to let people understand if you have a shooting pain, if you have numbness, tingling, you're not a good candidate for RF.
Correct. That's absolutely correct.
اوكي. الحقيقه سؤالي برضو او الحاجه اللي هنبتدي بيها النهارده اللي هي بنسميها الراديو فريكونسي ابليشن او نوع من انواع الموجات الكهرومغناطيسيه بتستخدم عشان زي ما بنقول كده يعني تقضي على النيرف اللي عامل بين. طيب السؤال اللي بيجي في بالنا كلنا، هل ده ينفع مع اي نوع من انواع الالم؟ انهي patients اللي تقدر تعمل النوع ده من البروسيجر؟ زي ما قال دكتور كوشار في البداية، ده لتآكل الغضاريف تحديدا في منطقة الرقبة في منطقة الظهر، ولكن هو أكتر للبين اللي هو يعني ما فيهوش معاه تنميل، ما فيش معاه مالوش راديشن، يعني ما بنحسوش في أماكن تانية في جسمنا. هدي لحضراتكم أمثلة، أنا بحاول بس أبسط قدر الامكان المصطلحات. لو انا عندي الم في الفقرات بتاع الرقبه، اول حاجه بنسال البيشنتس، طيب انت بتحس بتنميل في دراعك؟ الحاجات دي كلها بتحسه في مناطق تانية في جسمك؟ لو الاجابه كانت لا، معنى كده انه حضرتك كانديديت او نقدر نعمل البروسيجر دي عليك. لو البين متركز بس في منطقه الظهر، سواء في منطقه الرقبه، منطقه الظهر سواء الظهر من فوق او من تحت شويه، في منطقة واحدة بس، ملوش راديشن، ما بتحسش بتنميل او ما فيش شوتينج بين، البين ده ما بتحسوش مثلا في اماكن تانية سواء في دراعاتك او في رجليك، فحضرتك بيشنت نقدر نعمل عليك الجزء او البروسيجر اللي هنشرحها مع حضرتك. لو نشوف سلايد 5 مع بعض، زي ما قال دكتور كوشار ببساطة شديدة جدا، المفصل السطحي اللي بيبقى ما بين الغضاريف هو ده اللي بيبقى عامل المشكلة. بيحقن مادة الأول عشان يعمل زي تيست في البداية يتأكد إنه المفصل السطحي ده نتيجة تآكل الغضاريف اللي موجودة سواء في الرقبة أو في الظهر بشكل عام. لو التيست ده بيحقن مادة معينة، لو استجبت ليها بيبتدي يستخدم جهاز الموجات الكهرومغناطيسية اللي هي الموجات اللي هي البروبس الزرقاء دي اللي بتطلع الموجات اللي موجودة على النيرف، الموجات الكهرومغناطيسية اللي هي الموجات البرتقاني دي او الاحمر اللي موجوده تحت، والموجات دي بتتسلط على النيرفز دي، وبالتالي بتمنع الكوندكشن بتاعها او بتقفل الكوندكشن بتاعها. وده بيبقى نوع من انواع العلاج الجديد جدا بالموجات الكهرومغناطيسيه. وزي ما احنا قلنا مش كل مريض ينفع مع الحاجات دي، ولكن فكره تآكل الغضاريف بشكل عام بتبقى هي احسن حاجه للنوع ده من العلاج. Why rhizotomy sometimes is better option than medication?
Well,
like why it stands out sometimes? I know it's a tough question.
well, I mean, it's
an option.
I think, yeah, this is an option, but I think the answer is very kind of clear and obvious. I mean, pain medication, of course, is a solution. It's not actually a solution. It's a kind of Band-Aid with a lot of side effects. So patients who are like dependent on medication or pain meds, they have to wake up, take the medication, and if once the medication wears off, the pain come back, so they have to carry the medication with them. Radio frequency ablation provides, for people who are a candidate for it, provides a better pain relief.
Okay. For how long we're talking about? Like
6 months to a year.
6 months.
Yeah.
So is it repetitive? Like
Oh yeah, of
procedure?
course. I mean, once, and the patient comes back and tells me that, Doc, you did this injection on me, or did the radio frequency ablation, and then it's been like 8 months, 9 months, and I feel that the pain is gradually coming back. That tells me that the nerve is regenerating and regrowing back, the sensory nerve, and the pain is coming back. In that case, you schedule the patient for another test, the pain goes away, then we do the radio frequency. So RF ablation could be repeatable as many times as you want,
Okay.
but usually like 6 months to a year,
Okay.
not sooner than that.
I have a question here. They're asking you, how long is the procedure itself? How long?
Oh,
does
the
it take?
procedure itself?
Uh-huh.
It depends on how many levels we're doing, but usually roughly about 15 minutes.
Okay. So it's
I
not
mean,
that long.
someone who's skilled and knows what he's doing and
Like
can
Dr.
target,
Khoshsar,
and then,
right.
yeah, like Dr. Khoshsar. That's usually, it takes about 15 minutes to 15, 20 minutes to do the procedure.
اوكي. هي الموضوع بتاع الموجات الكهرومغناطيسيه اللي قلنا لحضراتكم عليه، زي ما قال دكتور كوشار، بياخد تقريبا من 15 ل 20 دقيقه. البروسيجر نفسها الافكت بتاعه او التاثير بتاعه بيقعد من 6 شهور لسنه. الميزه فيه انه تقدر تعيده اي عدد من المرات، زي ما انا قلت بيقعد من 6 شهور لسنه، وتقدر تعيده اي عدد من المرات. لو كل سنه مره يعني ما بيبقاش فيه مشاكل. مهم جدا زي ما انا قلت، بس عشان الاسئله اللي جايه لنا كتير، الموضوع ده للناس اللي عندهم تآكل في الغضاريف، والاعصاب الطرفيه مش جزء من المشكله. وزي ما انا قلت بنعرف ازاي انه مفيش اي حاجه من التنميل او اللي ما بنسميه، بيقول انا بحس انه البين مثلا بيضرب في رجلي من تحت او بيضرب في دراعي من فوق. الناس دي مش هي المريض المناسب للنوع ده من procedures. What's the complications expected from the rhizotomy procedure?
I mean, let me just wrap up the topic of rhizotomy very quickly of what are the indications. So someone with a back pain or neck pain, that pain doesn't radiate to the arms or to the legs, they could be a candidate for rhizotomy.
Okay.
We explain how it's done, and then also rhizotomy could be done on joints too. For example, someone who had a knee operation and is still having knee pain, or knee replacement is still having knee pain, we can go ahead and do a cooled RF, a cooled radio frequency, and kind of damage the little tiny nerves that go to the knee and provide relief for a knee pain.
Okay.
Or someone who has hip pain or pelvic pain at the SI joint, the sacroiliac joint, we can do the same thing and alleviate that pain as well.
Okay.
What are the complications? Well, we are causing a lesion in there, correct? So we are just burning a little nerve. If you burn other tissues around, or if you know what you're doing, then it can cause damage to the other tissues,
Okay.
such as damaging the nerve root itself.
Okay.
So that's one of the complications, but that's why we always test it. So this procedure is done under fluoroscopy. As we are going in and we're watching on a monitor exactly where we are going, where we are doing the procedure.
So it's
And then-
fluoroscopic?
Fluoroscopic, there we
Okay.
go. And then we test it before we burn it. So we do a sensory test to make sure that we are close to that little medial branch nerve that we want to burn. And when we do the motor test to make sure we are far away from the nerve root.
Okay.
So we are not burning the nerve root by mistake or so. But those are usually the main complication: bleeding, infection, and damaging the surrounding organs. But are very, very, very rare.
Okay.
Super rare.
I have another question here. Does it work, since you said it's local pain, does it work for peripheral neuropathy? He's a diabetic and he's asking.
Rhizotomy doesn't work for peripheral neuropathy.
Okay.
But we have other solutions for peripheral neuropathy
Okay,
that I'm going to talk about.
Okay. So that's good. So we have a new hope for peripheral
Sure.
neuropathy. We'll talk. Okay. الحقيقة زي ما قال دكتور كوشار، سألته ايه هي الأعراض الجانبية بتاع البروسيجر دي. قال زي أي بروسيجر ممكن يبقى فيها شوية بليدنج، ممكن يبقى فيه شوية نزيف خفيف، ممكن يبقى فيها انفكشن، انه يحصل انفكشن في مكان الحقن نفسه، وده بيبقى طبيعي جدا موجود في يعني بروسيجر موجود. طبعا بيبقى بنسب قليله جدا، طبعا كل ما زاد نظافه المكان، التعقيم، الحاجات دي بتبقى الحاجات دي نسبها قليله جدا. نسب النزيف تبقى قليله جدا لو بتتعامل مع طبيب زي ما دكتور كوشار قال عارف هو بيعمل ايه. ميزه كمان عمليه الرايزوتومي او الموجات الكهرومغناطيسيه، بقول تاني، للقضاء على البين الموضعي تحديدا. ده مهم جدا، اللي هو الالم المركزي نتيجه تاكل الغضاريف والنيرفز نفسها او الاعصاب نفسها مش انفولفد. الناس دي كمان بتدخل، لو نشوف سلايد 4 مع بعض، بتدخل تحت الترا ساوند وبتبقى بتحقن ماده عشان تشوف هي فين بالظبط. لو شفنا سلايد 4 هنشوف مع حضراتكم اللي على اليمين، اللي هي زي الكوره اللي على اليمين، دي الماده اللي بيحقنوها، وبيبقوا عارفين هم موجودين بالظبط فين وانهي نوع من الغضاريف، سواء زي ما انا قلت في الرقبه او في الظهر، اللي بتحقن على اساس ان احنا ما نعملش اي دامج او اي مشكله للاعصاب اللي موجوده جنبها. وزي ما انا قلت في سلايد 5 بيدخلوا بيحطوا البروب ده، وبعدين بتطلع الموجات الكهرومغناطيسيه دي يعني بتشتغل على الاعصاب اللي موجوده، الاعصاب الحسيه اللي موجوده، مش الاعصاب الطرفيه، وده فرق كبير جدا. الاعصاب الحسيه دي خاصه باحساس الالم بس، انما الاعصاب الطرفيه دي هي اللي بتدي الاحساس للاطراف وبتدي كمان الحركه للاطراف. دول ما بنلمسهمش خالص في فكره الموجات الكهرومغناطيسيه. اوبشن مهم جدا، اوبشن جديد بيدي امل كبير جدا للناس اللي بتعاني من تآكل الغضاريف زي ما انا قلت من غير تنميل في الاطراف، لانه ده مهم جدا. الحقيقه جالي سؤال مهم على التهاب الاعصاب الطرفيه مع مرضى السكر، اللي هو زي ما هي سمتها في المسج بتاعتها حاله الخضران اللي بتيجي للرجل، البريفرال نيوروباثي. للاسف الطريقه دي ما بتمشيش مع التهاب الاعصاب الطرفيه اللي عند مرضى السكر. ولكن زي ما قال دكتور كوشار، في طريقه جديده في العالم بتشتغل على التهاب الاعصاب الطرفيه مع مرضى السكر عشان تسكن الالم والتنميل اللي بيحصل في الرجل. هنناقشها برضو في حلقتنا النهارده. Anything else you would like to add about rhizotomy before we move to the next option?
I think we basically covered kind of the indications and how the procedure is done.
Okay.
But if there are like other questions or so, they're more than welcome to ask me.
Do we have any success rate statistics, or
I mean,
usually it's
what
successful?
dictates the success rate is a test. So
Right.
if when you do that test, when you block the little nerve, if it's positive, if you get good result, then the radio frequency is usually successful.
Okay. So, spinal cord stimulator, one of the most important options lately. You're one of the experts in those. So it's very important to teach us about what spinal cord stimulator in the beginning. When we say spinal cord stimulator, what does it mean?
So,
That's a very important. You
spinal
got excited.
cord stimulator is still considered a new procedure, although it's been in the market for about 35 years. But not to this advanced form.
Okay.
The first spinal cord stimulator came into the market was RF based, so it's radio frequency based.
Okay.
And the generator was outside and so on. So, but now we have very advanced technology in spinal cord stimulating. I'm the consultant panel member of a few companies that make the spinal cord stimulator. I teach for them. I teach other physicians on how to use the spinal cord stimulator and how to implant it, about the indications and contraindications of spinal cord stimulator. And I've done almost over like 1,000 implants of a spinal cord stimulator. Anyhow, spinal in a very, very simple format or terms, spinal cord stimulator is very similar to pacemaker.
Okay. Oh, that's a very good. It's like pacemaker for the heart.
Exactly. Like people who have pacemaker for their heart, exact same, not exact same, but very similar technology. The battery is actually the same size, but the battery is implanted in the buttock area.
Okay.
And the wires go in the spinal cord.
Okay.
They give electrical impulses to the spinal cord and they block the pain.
Okay.
Okay, let me correct that. They don't block the pain. They
regulate,
alter the feeling of the pain.
Okay.
Spinal cord stimulator is not a solution for everybody. It's for someone who has nerve pain.
Okay. So this time it's a nerve pain, like tingling, numbness.
Exactly.
Okay.
Someone who has neuropathic pain, someone who has pain radiating down the legs or pain radiating down the arms, someone who has shingles pain, for example, had shingles, and we have like post-herpetic neuralgia,
okay,
which is chronic shingles pain.
Yes.
Someone who had back surgery and they're still in pain and pain radiates down the legs. Okay, what are the options for those kind of people? Another surgery? So I've had patients, they went through first, second, third, fourth surgery.
The laminectomies.
And they get worse and worse and worse.
Okay.
Lami, fusion, and so.
Okay, so you answered my question, because my question was, we're talking here about laminectomies or spinal fusion or both of them together?
Any kind of back surgery I'm talking about, patient who had microdiscectomy, for example, because he had pain or sciatica. He's good for about a year. After a year, the pain comes back. Someone who had laminectomy and fusion, the pain comes back after a year. Why does the pain usually come back? Because there's scar tissue develops at the epidural space around the nerve root.
Right.
And the scar tissue puts pressure on the nerve, the pain gradually comes back, the pain goes down the leg again.
Any kind of manipulation can cause like scar.
Exactly. And then,
manipulation.
and the patients are good. Oh, I did this, I bent to pick up something and the pain came back. Probably ripped some of the scar tissue in there. But in general, the pain may come back after a spine surgery. Then there are complications of the surgery, such as infection, arachnoiditis. Those are like medical terms, but such as complications that happen after the surgery then can make the pain come back again after the surgery.
Plus the rehab.
Plus the rehab.
The rehab time is sometimes
it's
from
important.
6 months to a year,
It's very
just to
important.
recover.
But on those patients, what are their options? Taking pain medication for the rest of their lives?
Forever.
Going to have another surgery, which the success rate with each surgery drops by more than 50%.
Right. I have never seen like any surgery successful more than 50. And they tell the patient from the beginning, we have a 50-50 results, and still the patient pick the 50-50.
But still after the second surgery, the success rate is less than the first one. Like it's 50% less than the first surgery. So with each surgery, the success rate drops by more than 50%.
Okay.
So second surgery, the chance of recovery and improvement is about 25%.
That's true.
Third surgery, forget about it.
Right.
So what are the
about your
indications?
back, actually.
What are the indications? That's why people came up with spinal cord stimulator.
Okay.
So in my opinion, is the best option for people who already had the back surgery or neck surgery. They're still having back pain or neck pain with radiating pain down the arms or the legs. So that's the number one indication for doing the spinal cord stimulator.
Okay.
Number two,
So sciatica patients is in this
Sciatica
category
patient.
because I have a lot of questions from sciatica patients.
yeah, sciatica patient, but not a fresh sciatica.
Okay.
Spinal cord stimulator comes like is usually the last resort. I mean, sometimes we do it before the surgery, but usually it's after the surgery. So someone who has sciatica, first we try with the injections, epidurals, nerve blocks, then they decide to go for surgery. If they go for surgery, they come back, they're still having pain, then we can do that. Or some surgeon says, you know what, this patient is not a candidate for surgery. Go ahead and do the spinal cord stimulator.
Okay.
And a lot of patients, they decide to get it done. What are the advantages of a spinal cord stimulator?
I have a question for you here before
Ask
we
the
get,
question before I
we get
go
to
into
the
that
advantage.
topic.
It seems one of our viewers here, she's asking, she always have like numbness and tingling below her knee, about 20 centimeter after her knee. I think she had a spinal anesthesia before and that affected her lower half very much. Does any of those procedure can fix that?
Well, so she had spinal anesthesia.
Right.
So I
And up
assume
till
she
now, she
had-
feels numb, about 20 centimeter below her knees. And she's asking, her diabetes is good. She's taken a lot of vitamin B12 for it. So she's asking if any of those procedures can help her to recover the sensation, get rid of the tingling. Do you think the anesthesia, since you're like an anesthesiologist, can have anything to do with that?
Well, these are all based on my assumption with the little information that I have.
Right.
Spinal anesthesia has some complications too. It may cause arachnoiditis,
Okay.
some adhesions or inflammation inside the intrathecal space,
right.
and it kind of cause adhesion of the nerves, and so can cause symptoms. I don't know how they did it. They might have kind of nicked the nerve or damaged the nerve. But anyhow, any format that a patient is having pain below the knee and numbness and tingling, which we believe they're all neuropathic signs, nerve symptoms. In that case, the first thing that I do if I see that kind of patient, I do an EMG and nerve conduction study.
Okay. Okay.
So I do a test, basically, not myself. I send him to a neurologist to test by putting needles in the legs and find out exactly where the problem is coming from.
That's an excellent.
Is it from the peripheral nerve? Is it from the spine? And where the symptoms are coming from. Then I try to target my treatment based on the result of the EMG and nerve conduction study. But there's so many things could be done.
Okay.
So I want the patient to know that that's not the end of it. There are so many things could be done to treat your pain. And a spinal cord stimulator is one of them, is kind of like the last resort, but is very effective on any kind of neuropathic pain.
So she might be a good candidate for it.
Absolutely. But there are easier things to do to treat her pain.
Okay. That's why we have Dr. Khoshsar and other pain management specialists.
Sure.
Thank you so much. الحقيقة أنا يعني السؤال ده سؤال مهم جدا. مدام إنام بعتت لنا سؤال بتقول إن هي عندها تنميل في رجليها 20 سنتي تحت الركبة بعد فكرة التعرض لتخدير نصفي، بتاخد فيتامين B12 إبر. أولا قبل بس ما أجاوب على سؤال حضرتك، في العالم كله تقريبا ما حدش عاد بيستخدم الحقن بتاع فيتامين B12. دلوقتي في نقط تحت اللسان، النقط تحت اللسان بتبقى افضل بكتير والامتصاص بتاعها افضل، فبدل ما حضرتك بتستخدمي ابر لحد دلوقتي ده خلصت في العالم كله، ما فيش حد عاد بيستخدمها، ده بس بره الموضوع. فالنقط اللي تحت اللسان امتصاصها اسرع وبتجيب نتائج افضل. اجابه على سؤال حضرتك انه حضرتك ما عندكيش سكر، التراكمي بتاع حضرتك كويس، التنميل اللي بتحسي بيه 20 سم تحت الركبه زي ما قال دكتور خوشسار، الحقيقه فكره رائعه جدا. حضرتك بتشوفي حد نيورولوجيست تحديدا بيعمل حاجه اسمها EMG او كوندكشن ستاديز، بيعمل تيست للنيرفز وبيشوف انهي المشكله جايه من انهي نيرف بالظبط. بعد كده حضرتك ممكن تستخدمي حاجه السباينال كورد ستيميليتور اللي احنا هنناقشه دلوقتي كطريقه، وفي طرق تانية تقدري تستخدميها. انا مش عارف حضرتك موجوده يعني عايشه فين، ولكن لو حضرتك عايشه هنا تقدري تتصلي بينا وانا اوصل حضرتك بدكتور كوشار. بس انا ما اعتقدش ان حضرتك هنا، لانه فكره الفيتامين بي 12 حقن دي تقريبا خلصت من العالم كله. حضرتك ممكن تبعت لنا مسج على الانبوكس يعني، وانا لانه يعني الموضوع مهم جدا، فانا يعني هتابع مع حضرتك. بس فكره السباينال كورد ستيميوليتر بشكل سريع قبل ما ناخد بريك. السباينال كورد ستيميوليتر ده فكره زي منظم ضربات القلب. الناس اللي بتعاني من مشاكل في القلب عارفه انه في جهاز صغير بيتحط بنسميه منظم لضربات القلب، بيتزرع جوه الجسم. هي نفس فكره السباينال كورد ستيميوليتر، هو منظم لموضوع التوصيل بتاع الألم من الأعصاب الطرفية اللي بتبقى موجودة في الظهر. هقف هنا وناخد بريك وهنرجع نكمل مع حضراتكم أحدث طرق علاج الآلام المزمنة اللي موجودة في العالم. مبسوط جدا بالحلقة دي، الحقيقة متشرف ان انا قاعد قدام الراجل الضيف اللي معانا، لانه يعني الحقيقة عملاق جدا في الموضوع ده. فهناخد بريك، نرجع نكمل مع حضراتكم كل الجديد في علاج الآلام المزمنة.
Are you tired of being overweight? Do you suffer from diabetes? Do you suffer from hypertension? Do you suffer from obstructive sleep apnea? Do you suffer from hypercholesterolemia? Have you suffered from heart attacks in the past? Strokes in the past? Are you tired of being ostracized in public? Well, I have a solution for you. Robotic bariatric surgery. This can completely change your life. I'm Dr. Bobby Baskerau. I'm a robotic bariatric surgeon. I do robotic weight loss surgery, which can completely change your life. I offer 3 different types of surgeries that can completely change your life: the sleeve gastrectomy, the lap band, and the Roux-en-Y gastric bypass. One thing that's very unique about our program in that we have a dietitian, and you will get counseled on what to eat, what not to eat, and how to optimize the utilization of your tool for good weight loss.
اهلا بحضراتكم في الجزء الاخير معانا النهارده. زي ما انا بقول حلقه خاصه جدا، فخور جدا ان احنا بنناقش الحاجات دي في قناه الكرمه وبنفيد الناس بالشكل ده، لانه بنناقش احدث طرق العلاج في العالم اللي موجوده للآلام المزمنه بشكل عام. زي ما انا بقول حلقه استثنائيه، ردود افعال حضراتكم الحقيقه يعني انا متشكر جدا 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 للكلام الكبير جدا اللي بتبعتوه. بيسعدني جدا يعني رد فعل حضراتكم، ودايما بنحاول في وايت كوت وقنوات الكرمة بشكل عام ان احنا نساعد قد ما نقدر ونوصل المعلومة الطبية العلمية الدقيقة للناس. I have another question before we keep going on with
Sure.
And for vitamin B12 I didn't add anything, just to
No, I heard you were saying vitamin B12. I said, Tamer is adding vitamin
No,
B12
I'm
by
not.
himself.
I'm not.
You're a fan of it.
I'm a rep for the company. No, just kidding. I have another question. Good evening. God bless you. She has a herniated disc, lumbar 4, lumbar 5. Any solutions for the pain in my legs? Thanks a lot.
Okay. Herniated disc, I mean, there are so many different options to treat the herniated disc and sciatica. So, surgery is not the first option.
Okay.
Some people think surgery is.
We just talked about 50%.
Yeah.
50-50.
So, I would suggest someone with a herniated disc, if it's one level, without spinal stenosis, without narrowing of the spinal canal, and I assume that the disc is irritating the nerve, so the patient is having sciatica, the pain going down the leg. What I do, I usually start with just a couple of weeks of rest and physical therapy.
Okay.
If physical therapy doesn't help, next option is, I usually do as an interventional pain management specialist, I do epidural injection.
Okay.
Now, the epidural injection could be in form of transforaminal epidural, which is I go and give a selective epidural injection at the site where the nerve root is exiting, where the disc is pinching on the nerve. And then if that doesn't help, then what we do? So a lot of patients, they come in, oh, I had epidural injection. We can usually repeat the epidural injection 2 or 3 times. If the pain keeps coming back, which means that epidural injection won't help in long term. If it's an isolated disc, if it's just one disc that is bulged out, and we know that that disc is pinching on the nerve, what I suggest is to do a discogram, which means we go inside the disc, inject a little bit of contrast, kind of put pressure on the disc, and see whether that reproduces the patient pain.
Okay. So like mapping
So like a
the
confirmation.
Okay.
Of that's the one causing the pain.
Okay.
Once we confirm that, then I may do a laser microdiscectomy, only because it's one level disc, isolated, putting pressure on the nerve.
Okay.
That's what I think. However, usually that's not the case. Usually we have more than one disc, 2, 3 discs, pinching on the nerve, causing spinal stenosis.
Right.
We have arthritis of the facet joints too. Then the surgeon may decide to do a laminectomy, which means take the bone out and do a fusion.
Okay. Take
However,
the cartilage out.
Yeah, take the laminectomy means they take the bone out, like the lamina,
The lamina,
the
okay.
part of the bone to give more space to the basically the spinal cord and to the nerves. And they usually fuse it because then the bone will be weak. And then in that case, I have reservations. So I may want to try the stimulator first before laminectomy, or the surgeon may decide that no, she's young, healthy, good, let's do a laminectomy infusion. If the pain comes back, then we try the stimulator.
Okay.
But there are many options for treatment.
Okay. So she's asking for help. So yeah.
Yeah.
Okay. الحقيقة نجات بتسأل على الهرنيتد ديسك نمبر 4 نمبر 5 وبتقول إنه هي عندها بين بشكل كبير جدا. زي ما قال دكتور كوشار، رقم 1 ممكن نروح لفكرة الانجكشنز. كنا بنتكلم قبل الفاصل، الحقيقة الجزء ده أنا ما ترجمتوش، كنا بنتكلم قبل الفاصل على فكرة العمليات بتاع الظهر بشكل عام. دايما السيرجن أو الجراح بيدي يقول 50-50 والبين ممكن يكمل بعد عمليات الظهر، استئصال الغضروف أو الفيوجن، العمليات بتاع الفيوجن يعني دايما بيدي 50-50 بنسبة إنه الألم تكمل. كمان الريهاب أو الريكفري من العملية بيقعد تقريبا من 6 شهور لسنة، تبقى ريكفري فترة طويلة جدا. عشان كده بنناقش النهاردة الطرق الجديدة في علاج البين. زي ما حضرتك بتقولي إنه لمبر 4 لمبر 5 أو L4 L5 رقم 1 زي ما دكتور كوشار قال إنه الانجكشنز بيشتغل كويس جدا. حاجة تانية بيعملوا حاجة اسمها الديسكوجرام، يعني بيشوفوا الديسك الهرنيشن بتاعه قد ايه، وممكن يشيل جزء منه بالليزر زي ما هو قال. الحاجة الثالثة انه ممكن حضرتك تستفيدي من فكرة السباينال كورد ستيميوليتر او المنظم للنبضات العصبية اللي بتطلع من النخاع الشوكي اللي هنتكلم عليه في التوقيت بتاعنا. زي ما انا قلت السباينال كورد ستيميوليتر هو حاجة بتفيد الناس اللي عندها الألم في فقرات الظهر، وفي نفس الوقت بينتشر للأطراف زي الإيدين أو الرجلين. بيقول لك يعني البيشنت بيجي يقول إنه أنا بحس بسكينة بتضرب في رجلي أو في دراعي، دايما في تنميل في رقبتي في دراعي. الناس اللي عندها الأعصاب الطرفية مرتبطة بالموضوع ده، والتنميل زي ما أنا قلت في الأطراف، بيبقوا بيشنت كويسين خالص لفكرة السباينال كورد ستيميوليتور أو منظم النبضات العصبية اللي بتطلع من السباينال كورد ستيميوليتور. So as you told us in the beginning, spinal cord stimulator is like the pacemaker for the heart, right? So I have a lot of questions about that. First of all, do you screen your patients? Is there any way to screen them You said any patient with referred pain, numbness, tingling is a good candidate.
Correct. So to summarize that, anybody with neuropathic pain, nerve pain, could be a candidate for a spinal cord stimulator.
Okay.
What are the signs of neuropathic pain? What are the symptoms? The pain that is originating from the nerves. The quality of the pain is pain that is burning, numbness, tingling, sharp. These are usually the nerve pain.
Okay.
In other words, stimulator is not going to help with the joint pain. Someone who has a knee pain, that's not going to help. Someone who has a bone fracture or arthritis in the ankle, that is not going to help.
Okay.
It helps with the nerve pain. But a lot of patients are suffering from nerve pain and they don't really know that there's a solution for it. I see patients with shingles pain. They're referred to me for medication management. When I tell them that, hey, there is a device that can help you with your pain, they are totally surprised. Said, I've been suffering this pain for 20 years and no one really told me about it.
Okay.
So success rate with, for example, shingles pain is very, very high.
Right.
Putting the spinal cord stimulator in. Success rate with someone who has peripheral neuropathy. You mentioned that a patient asked that question.
A lot of diabetics.
Diabetic
They're very
neuropathy.
concerned.
So these are the pain that is coming from the nerve. The nerves are affected. So in that case, spinal cord stimulator would be a very good solution.
Okay. So
And actually there was a study done that showed that it not only helps with the pain, but it also causes a little bit of vasodilation, which means it kind of opens up the blood vessels. And if they have diabetic foot ulcer, that helps with healing the ulcer too. It's very amazing. They put it in Europe, they put spinal cord stimulator for angina.
Wow.
For someone who has intractable angina.
Tractable pain.
Yes, they put it in and it helps a lot.
Wow. So now you're telling me we have a new hope for all diabetic neuropathy kind of pain.
Correct.
Okay. And it's successful.
Very successful.
I'm just trying to declare this like in behalf of
Very successful.
Okay.
And how do we know whether it's successful or not? We do not implant stimulator not knowing whether it's going to help or not. The way we do it, first we do a trial.
Okay.
So, I mean, I have to answer your question, the first question that you asked me. What were the indications? Was that your question?
Right. Indications.
Who's a candidate, right? Or
Right.
how do you screen your patient?
Right.
That's what you asked.
And it's not just the current indication. I want to hear about the future or potential indications as well.
Correct. So how do we screen the patient? When I see the patient, the first thing, okay, the patient need to have a neuropathic pain, a nerve pain, to be a candidate for it. But does anybody with neuropathic pain is a good candidate for a stimulator? No. We talk to the patient. We need to set the patient expectation right. The pain does not completely go away.
Okay.
But if we can reduce the pain by more than 50%, hey,
Right.
that's a success.
Of course.
Right? Someone who's been suffering pain for a long time on a daily basis, if you can reduce the pain by 50%, they'll be way happier. But then we look at the social support of the patient, the family support that the patient has. We look at the patient whether he can operate a spinal cord stimulator or not. Like someone who sits in front of the TV and cannot even operate a TV remote.
Don't expect him to be a good candidate.
Probably cannot even operate, because stimulator, the patient carries a little remote.
Okay.
So they should be able to operate that remote.
Okay. لو نقدر نجيب slide 11 عشان I just want to show people like the remote for the.
Sure. And then we look at the psychological status of the patient. That's one of the requirements by the insurance companies to have a psychology evaluation before we move on to the stimulator trial.
Okay.
That's a Medicare requirement.
Why?
Why? Okay, I'm going to tell you why.
But I was curious.
It's all about, no, it's not all about that, but this device is very expensive device.
Okay.
So the cost of the device is about $25,000.
So you're telling me they don't want to waste their money.
They don't want to
basically.
waste their money. Exactly.
Okay.
Exactly. You got to the point. The cost of the device itself is $25,000. Now imagine the cost of the surgery, operating room, surgeon to operate. It all just pile up. And then, so the insurance company, they want to make sure that they are not losing their money.
Okay, since that has been said, what's the insurance coverage for a spinal cord stimulator? So you've been mentioning Medicare and insurance companies.
Medicare usually covers it 100%.
Wow.
A lot of insurances cover 100%.
So it's covered under insurance,
Oh,
so you
yeah,
don't
of
have
course,
to pay cash for it?
Of course, no.
Okay.
It's if FDA approved, has been FDA approved for years and years, and the insurance companies, they approve it. Why do they approve it? Because they did a study over 5 years. They calculated the cost of the medication and narcotics that this patient with chronic pain may use over 5 years, comparing to the cost of the device, the stimulator, is worth to go with the stimulator.
Probably admissions too.
Exactly. The cost of the medication is much higher than the stimulator over 5 years.
Yeah, those people don't joke about money. When
Exactly.
they make studies, they make studies.
Studies.
Right.
But at the end of the day, it comes about money.
Okay.
Which one is more cost effective?
Okay,
Medication versus stimulator. Stimulator is more cost effective.
okay,
And of course, it provides a way better relief too.
of course.
But what we're looking at with doing a psychological evaluation, we want to make sure the patient is not suicidal or homicidal.
Okay.
So if you put a device on someone and he goes and kills himself, like in 6 months,
I don't want to say
that would be a waste of money, right?
The money's gone. I don't want to say
the
it.
money is gone. So I want to make sure that the patient is not in that condition. Patient doesn't have major depression. Patient is competent enough to make the decision, which means it's not under influence. Patient is not drug addict.
Okay,
People who are addicted to medication and drugs, they'll never get better. They come back, they still say, oh, you know what? I'm still hurting, I want my medication.
right.
So
They
I want to make
relapse,
sure that,
like, there's a percentage of
and
relapse.
then we also talk to the patient. We want to make sure the patient is motivated enough to go with it. Patient wants to get better. Patient wants to go back to work rather than sitting at home and popping up medication.
Right.
So these are the things that we look at with the psychological evaluation. But once we set those goals with the patient and the patient's family, then we do a trial.
Okay.
Trial means we stick 2 needles in the patient's back. There is no surgery with the trial.
Okay.
We just put needles in the back, put the wires through the needle that go in the spinal cord or epidural space.
Slide 14. It's on
And
the slide
then-
14, if we can explain it
Sure.
to people.
Sure.
Yeah.
So we do a trial. Trial, we put the wires in through the needle.
So that's the trial.
That's the trial. And the patient goes home with the external battery that is wrapped to his back or just taped to his back. Go home and try it for 5 days, 6 days, a week,
Okay.
and see how it works. So patient goes back to almost his normal life, like goes to work with it, at home, walks around, and see whether it really helps or not. What we look at the trial is we want to see more than 50% improvement of the patient's pain or functionality.
Okay.
Does the patient come back, oh, my pain was, I didn't take pain medication this past 3 days. Someone who's taking 3 Norcos a day. Or I was taking my medication, but I was almost pain-free. Or I usually walk just around the house. I was able to walk like 2 blocks or 3 blocks and come back.
Physical activities.
So patient need to be happy with it. Patient tries it. Patient is the one who tells us, hey, I want to go on with the implant or no.
Okay.
So one of the advantages of a stimulator is that we know the outcome ahead of the procedure.
Right.
There's almost no other surgery that you would know the outcome ahead of the procedure. When you go for the spine surgery, you don't know how it's going to work.
It's just a matter of implantation later on. That's all
Exactly.
what it is. But you have tried it. It was successful.
Exactly. So if you ask me what is the success rate, is almost 100%.
100%,
Because we do a trial before we do the implant,
Makes sense, yeah.
right?
Right.
So that's one of the advantages of the spinal cord stimulator.
Okay, go ahead.
ahead.
So, no, sorry, go ahead. Number two.
Number two, the other advantage is completely a reversible procedure.
Okay.
So at any point of time in the future, the patient comes back and says that, hey, doc, you put it on me
Just take
4
it out.
years ago. I'm sick of it.
Just take it
I
out.
don't want it. Or I don't have any more pain. Or I want to go get a surgery done.
Okay.
Can you take it out? Absolutely. We take it out as if it never happened before.
Perfect. I just want to show people the picture here in slide 15, how you implant it, how you take it out. It's a very easy procedure.
Very easy procedure. Now, after a trial, when they come back to the office, we just pull the wires out.
Okay.
That's after the trial.
اوكي يا ريت نشوف بالظبط سلايد 15 زي ما حضراتكم شايفين ديفايس صغيره جدا هي اللي بتتزرع. هشرح كل اللي قاله دكتور كوشار. Let's take a phone call first. We have a phone call from Connecticut. مين معانا شباب؟ جرجس from Connecticut. اتفضل يا فندم حضرتك على الهواء.
يا دكتور.
اتفضل يا فندم حضرتك على الهواء.
عاوز اسال سؤال بس.
اتفضل.
انا جرجس ابو راميه. انا عندي فقرات في ظهري يعني تعبانين.
انهي فقرات في ظهرك؟
فقرتين تقريبا ما اعرفش الخامسه والرابعه حاجه زي كده من زمان ما اعرفش. بعدين بيجي لي الالم واخد بالك دلوقتي لما بشيل حاجه بتعب او تعبان دلوقتي في البيت قاعد. فسالت الدكتور مره قلت له اعمل مثلا عمليه قال لي لا جسمك ما يستحملش لانك انت كبير في السن.
اوكي حضرتك عندك كام سنه يا فندم؟ ربنا يديك الصحه.
68 عندي 69.
اوكي.
بعدين كلمته قال لي لا انا بروح له كل شهر او كل شهرين كل ما اتعب بيديني داكشن يعني 2 حقنه في الظهر. الحقن دي يعني فيها مشكله ولا ما تاثرش؟
اوكي حضرتك عندك تاريخ مرضي تاني لاي حاجه ضغط
لا
سكر؟
لا
بس
الضغط عنده سكر وما عندي سكر ضغط وعمل عمليات يعني وبتاع.
اوكي. He's a hypertensive patient, 60 years old, and he has lumbar 4, lumbar 5, sacral 1, and he has a lot of pain. And he usually...
I'm sorry, he had a surgery at the L4, L5,
No, he
and
didn't
S1?
get a surgery. It's only lumbar 4, lumbar 5. It's herniated disc problem.
Oh, he has herniated disc,
Right.
not a surgery. Then.
Right, no.
Okay.
And he usually uses injection. So he's asking, what would be an alternative? Is those injections good? Is a good option for him?
I mean, someone with a degenerative disc disease.
He's 68, 69, and the surgeon didn't want to operate on him.
Okay, well, I need to see the MRI and then see exactly what it shows in the MRI. Because someone with a degenerative disc disease at L4, 5, and L5, S1, it depends whether they have spinal stenosis also or no, narrowing of the spinal canal. Whether they have degeneration of the facet joints or no. So that kind of like the treatment varies.
Okay.
But the easiest, the simplest treatment as he's probably receiving now is injection in forms of epidural injection, for example.
Okay.
But epidural injection only helps with the disc pain, the discogenic pain. Usually in these people, they have facetogenic pain too. So it's good to target the facet joints too, such as having rhizotomy also in addition to epidural injection.
Okay.
If still it fails and the pain keeps coming back, then we have to look at a little more invasive options.
Okay.
If the patient is having spinal stenosis, then we can possibly put a Vertiflex and open up the spinal canal a little bit.
Okay.
To give him a better relief.
Okay. الحقيقه زي استاذ جرجس اسماعيل دكتور كوشار انه الانجكشنز هي الحل الاسهل بس مهم جدا ان حضرتك واحد تعمل MRI. لو حضرتك عندك النتائج يا ريت تبعتها لي انبوكس وانا هوريها لدكتور كوشار. الحاجه الثانيه الانجكشنز لازم يبقى نوعين من الانجكشنز وقال كمان ان احنا ممكن نستخدم اللي هو الجهاز بتاع الموجات الكهرومغناطيسيه اللي قلنا عليه اول حلقه بيعتمد على نتيجه MRI بشكل كبير. We have another phone call from New York. كمال من نيويورك. اتفضل يا فندم حضرتك على الهواء.
الو صباح الخير.
صباح النور. اتفضل حضرتك على الهواء.
I have a neuropathy that starts from the sugar diabetes. My sugar is very low. but I have a neuropathy. And the doctor starts me for tramadol 1 time a day. Until after like 13 years, I reach almost 3 times a day, plus gabapentin 400 milligrams. And I take for the sugar metformin.
Okay.
But I have too much pain from the feet, and plus, like 1 year, I have another pain coming from my back, and I take an injection. One time, it's for like a couple of months, and I have to come back to the doctor, and he told me I have to use it forever.
So you feel your pain is not under control? You feel your pain is not controlled at this point?
It's controlled with the tramadol. Without the tramadol, if I forget to take it further, it's too much pain.
Okay. So diabetic neuropathy, then you
solution, back pain and neuropathy, something like that.
Okay. We'll answer your question.
So what I got is that someone with diabetic neuropathy and also having back pain has been taking tramadol for a long time, and gabapentin also.
He's up to 3 times a day now of tramadol and gabapentin and injections, and it's not
he's also getting injections. I assume getting injection for the back pain, because injections don't help with the peripheral neuropathy.
Okay, that's what we're talking about.
So
the new
what are the options? The easiest option, as everybody knows, medication. He's on tramadol 3 times a day. Still considered, in the world of pain management, is still considered low dose.
Okay.
Because we usually go higher on the tramadol. We can just go up to 2 tablets 3 times a day.
Okay.
Or go to stronger pain medication. But tramadol is not necessarily a good pain medication for nerve pain. Gabapentin is.
Yes. Okay.
And gabapentin dosage of, I heard 400 milligrams 3 times a day. It's still considered low dose.
Baby dose.
The optimal dosage of gabapentin is about 2,700 milligrams a day. So once those are optimized, and if the patient is still having pain or especially peripheral neuropathy, the only other option I can think of that may help with peripheral neuropathy would be spinal cord stimulator trial. And
it's approved, FDA and everything.
Exactly. So we can try that. That may also help with his back pain too.
Okay.
So kill it, what would you say, the 2 birds with a stone or something like that. So we can target both back and the leg with putting the spinal cord stimulator in.
No B12.
No vitamin B12. No.
اوكي. الحقيقه استاذ كمال من نيويورك زي ما قال دكتور كوشار، والحقيقه وده كان واحده من المسجز اللي عايزين النهارده نمررها للناس. كل الناس اللي عندهم مرض السكر بيعانوا من التهاب الاعصاب الطرفيه اللي بنسميه البريفرال نيوروباثي. امل جديد جدا ليهم اسمه سباينال كورد ستيميوليتر، او زي ما بنسميه منظم النبضات العصبيه اللي موجوده في الاعصاب الطرفيه. امل كبير جدا وامل مهم جدا ليهم اللي هو سباينال كورد ستيميوليتر لكل الناس اللي بتعاني من التهاب الاعصاب الطرفيه. زي ما حضرتك سمعت استاذ كمال انه السباينال كورد ستيميوليتر ممكن يكون حل لحضرتك، لانه ستيل ممكن نطلع مساحه اكتر في الدواء، ولكن فكره كمان الانجكشنز كل شهرين ما اعتقدش هتبقى يعني كفايه قوي، بما انه حضرتك موجود هنا في نيويورك. الانشورنس ميديكير زي ما قال دكتور كوشار معظم انواع الانشورنس بتغطي فكره السباينال كورد ستيميوليترز، فده شيء كويس جدا. ممكن حضرتك تسال عليه الاخصائيين اللي موجود في نيويورك، او لو حضرتك طبعا تشرف في كاليفورنيا اي وقت we'll take care of you. The time has gone so fast, so
no way.
Yeah, so we'll, with a promise, with
so
another
many things
episode,
to cover still.
Finish, of course. We have a spinal cord stimulator, pumps, and Vertiflex. We can cover him in another episode.
Absolutely.
Thank you so much, as usual, Dr. Khoshsar. It was an extraordinary episode. Thank you so much for the knowledge. And what's the website again, very quick?
biohealthpain.com.
biohealthpain.com. تقدروا حضرتك تدخلوا على الانترنت biohealthpain.com. الناس اللي عايشه في كاليفورنيا اي حاجه خاصه بالامراض المزمنه، واحد من احسن الناس في المجال ده. بشكر حضراتكم على كلماتكم الرقيقه جدا والمشجعه جدا على الفيسبوك كالعاده. بشكر حضراتكم على التفاعل، ونشوفكم على خير وحلقة جديدة من وايت كوت الأسبوع الجاي.